So you can see the technology side is throwing in, science side is throwing out a lot of materials to us, and now the question is how are these going to be uptaked by the other sectors? And so what we're going to turn now to is sort of this demand side of looking at these from the perspective of three different stakeholders, starting with payers. Obviously, the bottom line is money often, and we have an excellent expert to speak to us about this, Diana Petitti, who's worked extensively in academia. She's in our Department of Biomedical Informatics here at ASU, but she's had extensive experience both in the government at the CDC and also working with Kaiser in industry, and so she's got a lot of familiarity with both public and private payers. So, Diana?
Well, I appreciate being here, and I would want to emphasize that my role here as a person talking about the payer perspective is from my 15 years spent at Kaiser Permanente in Southern California, where I was a member of the technology assessment team there and was intimately involved in numerous decisions about deployment of technologies. I'm talking about, I think there are a number of different perspectives that are reflected in this conversation, but I want to point out that there are perspectives that may not be reflected. There's the patient, provider, purchaser, payer, policymaker, and product developer perspectives. Now, when people talk about payers, they think of insurance companies or companies that act as insurance companies like Kaiser Foundation Health Plan, United Healthcare, WellPoint, Aetna, Cigna, and there is a view of payers being on one side and technology developers and patients and perhaps providers and being in the other side. But what I would point out is that the biggest payer for medical care in this country is actually not an insurance company, but the government. And CMS, Medicare and Medicaid, taking care of the elderly and the disabled and the poor, plus the Veterans Administration, plus TRICARE, which is active military, pay for more than 50% of all medical care in the United States through these programs. And I think many of you know, if you've looked at your W-2 form, that general tax revenues and the money that you pay to the government is really the source of these payments. So, in fact, everyone in this room who gets a paycheck is actually paying for Medicare. I think we forget that. An even broader view of payers goes down to the point that businesses are payers for medical care through their purchase of insurance on behalf of employees. And increasingly, I think it's lost. I think economists will definitely understand this viewpoint that businesses pay for medical care and health care by paying for the time off work that their people spend in partaking of medical care or health care more broadly. Patients actually are payers. They pay for their insurance directly. They pay for the insurance deductible for those types of products. They pay the amount of any co-insurance, and as you know, co-insurance is a percentage of the total allowed charge that a patient pays out of pocket for a set of services. They pay co-payments. Even when one is insured, patients pay directly for desired or needed care that is not covered by their insurance, either because their insurance chooses not to cover it or because they meet some hypothetical limit on their insurance. That'll go away, by the way, in the Affordable Care Act. Patients pay for medical care through lost wages. So my point here is, and I'll come back to it later, that we all have to put ourselves in the role of payers. Now, I'm going to go back to the insurance perspective, and I'm going to be a little, hopefully, there people here are not so cynical about insurance companies that they don't believe, at least partly, that insurers or payers actually do want to have good clinical outcomes. However, insurance companies also want to have and need an ability to maintain affordability. I was thinking about this talk, which I kind of wrote like most people on an airplane, or parts of it. And this was actually a quotation from the February 27th Wall Street Journal, where they were talking about some problem of a company not being able to make sufficient progress in getting their something approved by the FDA. But they quoted a patient, and I think this is really very apt. This was a patient who had a treatment for juvenile rheumatoid arthritis. It turned out that she had 2 children who had juvenile rheumatoid arthritis. There was a new drug for this. It cost $69,000 per year per person. And since January 1st, they were having trouble meeting the $2,000 copayment or copayment imposed by the insurance company. This morning we heard, I think, Dr. Topel talk about the idea of unaffordable success. And I think this perhaps is an example of unaffordable success. The insurance company paid for this, but at what point can an insurance company, or should an insurance company say that the price is too high? The issue for insurance companies, the issue for CMS, the issue for Medicaid, Medicare, the VA, TRICARE, Kaiser Permanente is affordability. It is affordability. This is an example. Here is a description of the national medical care expenditures by source of payment, and you can see that starting in 1980, out-of-pocket expenditures for patients were 22% of the $256 billion, but the number of billions of dollars in 2010 had increased by a factor of 10, and the out-of-pocket expenses were 11.6%. This shows data from CMS, Center for Medicare and Medicaid Services, about the consumer out-of-pocket payments for health expenditures from 1990 to 2000, and you can see they've increased to $320 billion. Now, given the affordability issue, the payers approach technology, and we did this at Kaiser Permanente as part of our regular assessment of new technologies, was to go through really pretty much a 3-step process. It's more complex because it requires a lot of evidence review, but the first question is, does it work? Does it work at all? It's quite amazing how many technologies will be proposed for use and for payment or deployment when the amount of data to support the use of that technology is 10 people more than 5 rats. This is particularly true in the device industry when the devices are not regulated by the FDA, and in surgical innovations where someone will want to do something complicated where there is no regulatory authority, so they simply have to propose doing it. After the question is answered, does it work, and there's some kind of evidence that it does work, the question is, in whom? And in how many people is this technology or new technology likely to be useful or used? The next question is, how much does it improve net outcomes, meaning the benefits compared with the harms, compared with the alternatives? Because each new technology has an alternative strategy for management. Sometimes it's nothing, but often it is a replacement technology. This is particularly true with device and surgical innovations. And then the third and last question is, how much does it cost compared with its alternatives? And costs are not simply the unit costs for a system, for example, like Kaiser Permanente, but the costs of deployment. I think Dr. Post mentioned the enormous challenge of attempting to deploy complex technologies that require major systems changes and massive amounts of education. Payers in general have almost all payers, insurance companies, have some kind of formal mechanism for conducting technology assessments. either directly for the large companies like Aetna or United Healthcare, or relying on for-profit or not-for-profit entities such as the Tech Center for Blue Cross and Blue Shield to assess the evidence and determine whether it works, determine whether it improves net outcomes compared with the alternatives, and then to bring in some amount of information that assesses whether the cost is reasonable compared with the alternatives. I want to go back to the idea that we've heard a great deal here about the perverse and entirely dysfunctional system that we have for paying for medical care. It actually removes people from the payment assessment. It makes it seem that insurers are the only payers and creates a false conflict between patients and providers and the people who give out CPT codes and or decide that they are going to pay for something. Insurers actually ask the question all the time, can we afford to offer this and still remain profitable, or remain in business, or remain affordable? Kaiser Permanente and other insurance companies are well aware that there is a direct trade-off between the cost or the premium for health care and the number of people who are actually willing to pay that and can afford it. Government, as the ultimate payer for 50% of all medical care, is asking the question, and we had a person from CMS here or someone from Medicaid, they would be asking the question, can the nation afford to pay for these services, these medical care services, and still pay for all the other things that are making demands on public resources, including roads, schools, bridges, et cetera, et cetera, et cetera. Patients who are increasingly becoming aware of the cost or the payment for medical care are asking, can I really afford to pay this amount for health care? And this is clearly, as we get into the discussion of the Affordable Care Act, people are going to be faced with a mandate to purchase something that they may or may not feel that they can afford. It's noteworthy, and this has been mentioned in a number of, not here, but in a lot of other settings, that 60% of all personal bankruptcies are directly related to medical care costs. The inability of a person, even a person who is insured, to be able to pay their bills. 20% of $1 million, and many insurances have 20% co-insurance amounts, is a lot of money, and can bankrupt almost anyone. So again, as we, to summarize, I hope that you will believe that insurance companies actually do want to do the right thing, that they do need evidence that the technology works and that it improves net outcomes compared with alternatives. We haven't talked about it. I think Dr. Post mentioned there are considerable challenges in obtaining good evidence about new technologies, evidence that is convincing to those who are being asked to pay exorbitant sums for things that may or may not have large effects on net outcomes, and this is the main message here, that affordability and maintaining affordability of health care is not just an insurance issue. It is a societal issue, and we are all payers.